Any questions from last time? I was working yesterday, and the most interesting thing that happened that day was that I actually got into a dad joke battle with another dad pharmacist that worked with me that day. I wasn't gonna, huh? I didn't have to whip out the book, no. I was come prepared for battle. And so I'd said to one of the technicians or something, I said, hey, do you know where pirates like to get their hooks from? And she goes, no. And I say, the secondhand store. And he goes, whoa there, buddy. He goes, do you know what kind of computer makes the best music? Adele. I said, no, I'm not going to have that. My pharmacy. I said, well, why did Adele cross the street? To say hello from the other side. He had no rebuttals. I won soundly, so. Anywho. Talking about cystic fibrosis, have you guys covered this at all, perhaps anywhere else? Yes? A little bit? What is CF? Not really an autoimmune condition. Buildup of mucus, that's a very good issue that pops up with, well, not a very good one, but it's definitely a prominent issue that pops up with these patients here. Why do they build up mucus? Yeah, these chloride channels kind of get a little, they don't work quite so well. Anyone know why? It's genetics, yeah, it goes back to their genes essentially, right? So, in a lot of, and again, you typically see this more in Caucasian patients, it tends to be more spread through those genes. And again, it's an autosomal recessive thing, so it's one of those things that you may not know you carry a gene for, but perhaps if you get with someone who does, then you can have kids. And you'll see sometimes they'll have like whole families that will have like 3 or 4 kids that have CF together. So like I mentioned, this is going to be an issue with the CFTR regulator. So basically a transmembrane protein that is responsible for transporting sodium and chloride. And it helps with kind of this recycling of secretions and things like that. And so basically what you end up finding is it's not able to kind of take back in that chloride. The sodium can flow through fine, but it's the chloride that has an issue there. And so you tend to find they get these like really thick, tenacious secretions that develop there. I only mentioned the specific mutation here, this delta F508, because that actually can play a role in determining which medications. There's a new class that we'll talk about a little bit later on. That only works for patients that have this particular mutation. There are others that are out there, but this is probably the most common one you'll run across, at least in the US. So basically what you end up finding is because you can't transport that chloride ion, that the fluid secretion tends to be pretty insufficient. Anyone know what kind of like skin manifestations you can find there? They have this like kind of frosting of the skin basically because they have all that chloride sitting out there. So if you were to say lick a baby with CF, this is how you would kind of test it back in the day before we could test for your genes and things. They'd be a salty baby. That was kind of the, I don't recommend doing that now, but basically you'd find they have this kind of frosting of the skin where they have all this chloride kind of left out there. So that's kind of one of the things that's kind of indicative of that. This is something you do test kids for at birth nowadays, or you could actually test yourself to see if you carry the gene. If you did like a 23andMe kind of thing there, it can tell you if you actually carry one of these copies. But basically what ends up happening though is you end up obstructing a lot of these ducts, a lot of plugging and then dysfunction at the organ level. So a lot of different organ systems are going to be taking a hit here. We'll kind of walk through a few of those just to give you an idea of kind of what manifestations occur and how we actually treat that. And so some of the meds we'll talk about specifically for these kids, we'll find that you can also use for other things as well. So I'll kind of make mention of those as we go through here. So anyway, as I mentioned, we're going to have these like really desiccated respiratory secretions. What do you think that puts the patient at risk for? Infection is going to be a big one we're going to see. And so very frequently we'll find that patients will get admitted for what we call like a CF tune-up, essentially, where they come in, have some sort of pulmonary exacerbation, and we'll be giving them lots of antibiotics. And so we'll find that it's pretty difficult to treat these patients in terms of getting to the site of infection, as we'll see when you have these secretions we're dealing with. So, and again, the lung stuff is what accounts for, a majority of the morbidity and mortality with these patients. And I've seen some CF kids go on to actually get lung transplants in order to help actually take care of this issue here. But what you end up finding is that due to this kind of chronic obstruction, they get these really dehydrated, sort of like really thickened secretions, and then they end up harboring a lot of bacteria. And we'll talk about some specific ones that tend to be more common or more kind of problematic in these patients here. They also have a really kind of exaggerated inflammatory response. And so we'll look at some meds that we can use as an anti-inflammatory to actually help to manage that. It's not the ones you probably might be thinking of potentially. And again, you get just a kind of progressive respiratory disease. Basically, by having that thick, tenacious sort of secretions, if we can't do anything to help out with that, then they end up developing bacteria that will grow there. Anyone know which particular bacteria are problematic for these patients? Pseudomonas will be a big one, right? So we're going to find that Pseudomonas typically gets like really, really resistant. And when talking about like different organ systems that you want to get antibiotics to, which ones are kind of typically pretty difficult to penetrate? The lungs would be a big one. What's another one? The CNS, yeah, for like meningitis, like only certain medications will cross the blood-brain barrier if you're inflamed, but the lungs can be another really difficult one to penetrate. And so we'll look at kind of whole regimens that we use for these patients in order to help, one, clear the secretions out, actually get them out of the lungs, and then other things we can give to actually get and treat the bacteria themselves. And so we'll talk about like chest physiotherapy and things like that to help kind of clear all that junk out of their lungs. If you can kind of look at this in a pictorial example, normally you'd have glands that are secreting mucus and they can clear it no problem. Here they tend to get obstructed. And again, all that obstruction tends to lead to a lot of inflammation, which furthers the lung damage that happens in these patients. And so here you can just might imagine just total blockage there of those kind of terminal bronchioles. You're going to see a lot of inflammation because of that. So just going to give you a pictorial example. Other things we're going to find is that with this kind of repeated, kind of recurrent bronchitis, you're going to find these kids will have to come in a lot especially if they're not really managed that well, or if they get stressed out or they get sick, they'll end up coming into the hospital quite frequently for these kind of long stays. And sometimes, you think about a typical treatment, say like a typical pneumonia, how long would you treat for? 7 days, 10 days, maybe 14 days, depending on severity. Here, we can give these kids like 21 days of therapy just because it can be quite difficult to actually get there. And again, they're going to have a really kind of exaggerated inflammatory response because of all this, they're trying to deal with those bacteria, but they can't really get to the actual site to pass them or to actually deal with them. But so they typically are going to be colonized, which essentially is they're just going to have the bacteria there always, and you can't really get rid of them. Can't really entirely sort of eradicate the infection itself. And again, we'll see some ways we can actually deal with that as well. But some things you're going to see typically in terms of organisms include things like Staph aureus, right? That can definitely, if you have these patients kind of getting antibiotics kind of repeatedly, what do you worry about developing? MRSA, certainly, right? So we end up developing more resistant Staph aureus here. But most of your respiratory bugs are going to be an issue, right? So, strep pneumos, H. flus, and things like that. But then now we're going to add in certainly things like Staph aureus and Pseudomonas will be another big player here. And so you have to make sure you're covering for those types of bugs. And we'll talk about some antibiotics that can do that. So you want to start thinking about what drugs you might use to cover MRSA and Pseudomonas and things. You end up finding kind of late emerging organisms too, and if your patients with CF start to actually grow these, that's kind of an indicative sign of, kind of a progression of disease, because normally we get exposed to these kind of bacteria all the time, but we can fight them off. We don't really have an issue here. But if you start to see things like Stenotrophomonas, things like Burkholderia cepacia, that tends to be a little bit more worrisome, and they tend to be a little bit more resistant. Not only that, we start worried about Aspergillus and other kind of fungal infections could be a risk as well. So what happens with these patients here with their Pseudomonas, there's two main types. There's a mucoid and a non-mucoid. Typically, if you have a patient with, say, no CF and they have a pseudomonal infection, it's a non-mucoid type. What happens is they end up developing this basically kind of protective barrier around themselves such that they are now even more difficult to treat. So not only are they in a site where it's difficult to get drugs to, but now it's even more difficult because the bacteria are trying to protect themselves even more. So we're going to see that getting high levels of drugs in the site is going to be paramount here. So how do you think we can get really high levels of drugs into the lungs? Yeah, we'll see actually instead of using maybe systemic therapy, we might have some of these patients using, say, inhaled therapy in order to get high concentrations there. But again, you got to think about all that mucus blocking up those airways. We can try to clear that out first, and that allows our antibiotics to work a little bit better. We'll see how that works just a little bit. So, and again, if you did like a culture and sensitivity, like say you did a BAL, you know what BAL stands for? Yes, thank you. Bronchial alveolar lavage. That'll give you a good sign of what's actually there in the lungs, and it will tell you if it's mucoid or non-mucoid. They'll actually test for that. Typically, you'll find like a CF respiratory panel, and it's a little bit more broad, and we'll look for things like that. So as I mentioned, they'll come in for these kind of acute infections, these exacerbations that occur. And again, you know what to look for. It looks like a typical pneumonia for these patients here, but they tend to get pretty dehydrated as well, which will be important when we're looking at things like renal function and things like that for these patients here. And so they'll be in the hospital for, say, 2 or 3 weeks or so for what they call like kind of a tune-up. What's the risk of being in the hospital for that long, though? More infections, right? So infection control is really important. It's appropriate that you wear things like appropriate PPE to make sure that they're not spreading anything respiratory to healthcare providers to send to another patient and vice versa, right? So when I say PPE, what does that stand for? Personal protective equipment, right? So things like make sure you're wearing a gown, make sure you're wearing a mask, respiratory protection, things like that, right? So anyway, so what we're trying to do here is, and again, you can't really eradicate a lot of these bugs because they're just colonizing the patient at that point, but we try to get a nice suppression of the bacteria and then kind of restore normal balance. Hopefully they're going to be oxygenating well, they're breathing well, and then we can send them on their way. So other issues that pop up here, it's not just the lungs that are going to be affected, although it's kind of typically what you think about, but what do you think could happen with the abdominal tract? The gastrointestinal tract, I should say. Well, a lot of other secretory organs are also going to be affected. So for instance, like what do you think might happen with, say, the pancreas? Going to get blocked up, right? It's going to get blocked up and it can't send out all those nice digestive enzymes. So what happens to those enzymes that want to get released, but they're stuck there in the pancreas? Auto-digestion of the pancreas, right? So what could that lead to? Diabetes, actually, right? So a lot of patients end up having insulin on their profiles as well because they're developing diabetes because, again, the pancreas is sending all those enzymes, they got to do something, so they're just going to start digesting whatever's nearby. Not really all that selective in those cases there. You also can see things like ileus. That's actually one of the things you'll find with those newborns that have CF is they can actually have this meconium ileus where basically they can't actually even pass the meconium, which is that first stool. And so that could be another thing kind of triggers you to think like, oh, maybe this is CF in this patient here. And then some other things will pop up here as well. Certainly they have a lot of things like bile acid reflux and things like that. Certainly the biliary tract can be affected here as well, so look at some other ways we can actually treat that. And they also tend to have a really hard time absorbing a lot of fat-soluble vitamins, which are A, D, E, and K. Very good. So you're going to find that this is really important. So from a nutritional standpoint, we have to make sure that we are supplementing what these patients can either not send out on their own or help them to give them extras to actually absorb. So and that can lead to lots of issues. So if they have a hard time absorbing vitamin K, what do you think could happen? Things like bleeding risk. Why? They can't make clotting factors in the liver, right? So that's something you can actually look for to see, okay, well, did they really have a malabsorption issue? How would you check to see if they're not making clotting factors in the liver? Yeah, you can check a PTINR just like you would check for warfarin, for instance, right? So again, think about these kind of processes kind of being similar, right? Whether it be a drug or whether it be due to the disease state. And so what do you think their stools might look like if they're having a hard time absorbing things like fat-soluble vitamins and fats in general? Yeah, so steatorrhea might be something you can see there. There's really foul-smelling, oily stools and things like that because, again, their pancreas isn't working to send out all those lipases and whatnot. And so enzyme supplementation will be another big thing we'll look at in just a little bit. You get that biliary sludging that can occur there, so we'll actually end up giving something called ursodiol or Actigol that actually works as kind of a supplement. So if they can't send out their own bile salts, we can kind of supplement that. So urso, anyone know what animal that might refer to? A bear, yeah. So we actually developed this drug off of bear bile initially. So I don't know what type of bear, whether it be polar or grizzly, but that was originally where it actually came from. So the brand name is called Actigol, and so you can kind of think gallstones, gallbladders, so it kind of leads you to, you kind of know what kind of drug that is. But ursodiol is something we can actually give, and it helps to supplement. And again, it helps with better absorption for your foods and things like that, especially with fats. But certainly, though, if they're having this backup here, you can end up developing all the signs of biliary cirrhosis that can develop there. So, icterus and ascites and all that because they can't process all that bilirubin and whatnot. Chronic appendicitis is another thing that may pop up because of this. Again, just things are not really secreting like they should in the GI tract. As I mentioned with the pancreas there, a lot of patients end up developing some degree of insufficiency, right? So this is kind of like this malabsorption that occurs here, maldigestion. Typically, these patients, do you think they're overweight, underweight? they're pretty thin, right? Because they can't absorb a lot of the nutrients you're actually getting there. So frequently, and I wish I could participate in this kind of diet, but it's very high fatty foods they're getting frequent snacks and things like that. Unfortunately, though, it's just bad things happen if you don't have CF and that occurs. But I guess it's a trade-off. But yeah, failure to thrive is a frequent thing you'll find in these patients here. Typically pretty thin for the most part. We'll talk about some ways we can supplement that. Again, hyperglycemia, mainly due to insulin insufficiency. So even though it's more of an endocrine function of the pancreas, it will suffer as well because the exocrine function can't work and it just auto-digests the pancreas there. So frequently, we'll have to end up maybe supplementing with insulin. We find that in some of these patients here. You don't really see them develop like DKA like a typical type 1 diabetic patient might. It may still have some insulin secretion, but it's not going to be a total loss like you may find with a typical, like a more of an autoimmune kind of type 1 diabetic. But even things like the genitourinary tract can be affected as well. Frequently, these patients may be not able to procreate because, again, things like the seminal vesicles and things like that are not going to be working. You can find all kinds of things like amenorrhea that can develop from this. Lots of other issues in terms of fertility can occur with these patients, which maybe that's something they want to do. If they have a partner who does not carry any copies of the gene, maybe they want to procreate. Who can say, right? But this can be another problem you can see. Not too many drugs we're going to find that will affect this specifically. But we'll look at some other things we can do for them. We talked about the salty tasting skin. So again, I don't recommend licking just random babies or any babies at all. Although I did find, so yesterday my shift started at 6 a.m. And so my 2-year-old decided to wake up at 4 a.m. to start the party early. So I had a nice wake-up call. And so as I'm waking up with the baby, because my wife said, no, you take her, I've got it. I've done this enough tonight. I said, okay. So anyways, I'm lying on the couch. Baby crawls up on me, and I'm thinking, okay, so where's the closest orphanage I can send this kid to? And I figured babies actually have they have like a survival mechanic built into them. And so she like kind of climbed up on me, laid on me, and then she actually grabs my arms and like pulls it over her. And I was like, I'll keep you. You'll stay in the family another day. So it's actually smart, it's like just an inborn sort of instinct for them. So, but anyway, yeah. So again, you can definitely see they can develop hypochloremic alkalosis, and again, it's because all that chloride is being stuck out on the outside of the skin. So you may see that, especially if they're in a kind of hyperthermic state, they're sweating potentially. That's where we can actually develop that. So low chloride levels may be a possibility. All right, so how do we manage these patients here? You're going to see that they're going to be pretty frequent kids. So if you're working like in a children's hospital or something, if you work with the pulmonary team, like you'll find these are pretty frequent visitors to the unit. This is really important though, that say for instance, like you had a patient with CF who is traveling. We see that often. We have a lot of Make-A-Wish kids that will come into town to go to Disney or go to Universal or wherever, and then they get sick and they may come over to see us as a result of that. You have to have a lot of history on them because things like previous cultures, right? Why would that matter? I want to know what kind of susceptibilities and what kind of things they've been growing before, such that if they are, say, resistant to, say, piperacillin, I want to know about that because I don't want to start that patient on piperacillin because it's just not going to be that effective. So history is really important for these patients here. Make sure you can contact their other providers and get some idea of what they've been on before. The other thing you're going to find is these patients typically, especially due to some of the issues of sweating and whatnot, they tend to get dehydrated pretty significantly. And what do you think it does to all those secretions as well? Dries them out even more, right? So again, they just get really, really congested from all of that. And so typically these patients will come in and you may look at their labs and think like, well, it looks like their BUN's up, it looks like their creatinin's up, maybe the renal function's not great. A lot of it has to do just with dehydration and sort of a pre-renal sort of azotemia. Basic IV hydration needs to be kind of started off pretty early. So you want to kind of tank them up, get them back full of fluids, and that will help out with secretions, it'll help out with a lot of things. Everyone feels better after a liter of fluids, right? What's a good dose for a liter or a fluid bolus for a pediatric patient? You should know this. This is good. Good to know. Fluid bolus would be, it's a number, just any random number. 20 mLs per kilogram, right? Would you like cap that out anywhere? Remember, you can always give more fluids, right? So I'd probably cap it out at a liter for most pediatric patients, right? Now, if they come in and they're hypovolemic and they're bleeding and they're a trauma patient, yeah, you can give more than that for sure. But usually you can always give more fluids if you need to. It's hard to take it back, right? How would I take back fluids if I gave too much? get diuresum, right? But then you're adding on more drugs, not great. Dialysis, right? Things like that. So there are ways to do it, but it's not fun, right? So usually cap it out about 1 liter. So what type of fluids would you use? Normal, why normal saline? What makes it normal? Did I hear isotonic? It's an isotonic fluid, that is true. What does that mean? It's the same tonicity as our blood essentially, right? So what's in normal saline? 0.9% sodium and chloride, right? And we know the concentration of sodium in a bag of NS? Close, higher? 154 milliequivalents per liter, okay? So add that to 154 milliequivalents per liter of chloride, and what do you get? 308, right? Milliosmoles per liter. What's our normal tonicity of our blood? Between 280 to 300. See, so it's isotonic. It's about the same as our blood there, right? So that's why we do that. And then what's our normal sodium level? 135 to 145, right? 154 is not bad. It's pretty close. So that's why it's normal saline, right? So that's why we bolus patients with that, because it's isotonic. It'll help to replete the fluid status is just going to stay in the intravascular space, right? We'll talk more about that at a different time, I'm sure. But little things to kind of think about, like why is normal saline normal? Why do we call it the great toad? Why is it so great? Right? These are things that you should ask yourself. Anyway, but again, ask for, look at your PFTs, look at changes that have been occurring in these patients. You want to make sure you get a good history on these guys. And again, make sure you're considering things like the nutrition. Get your nutrition team involved in these patients. They have a lot to say for sure, because they'll look at things like their stools, they'll look at their weight gain, they'll look at all kinds of things to see like, what do we need to do in terms of their nutrition. From the pulmonary standpoint, what we want to do is to get rid of those secretions, right? Is there anything from a drug standpoint we can do for that? We're in a pharm class. I'm going to say yes, there are. We'll look at some ways to do that, but we'll also see that actual chest physiotherapy, things to actually help to clear that, will be another big component there. We'll look at how we can use those in conjunction with one another. The other big thing is to help control the infection, right? So that either if we get rid of it, that'd be nice, but suppression is probably going to be the name of the game for a lot of these patients. So we'll look at things like inhalational therapy and then the antibiotics we're going to use for these patients here. So, as I mentioned, chest physiotherapy, this is one thing that you'll find a lot of CF patients, especially when they're teenagers, they're not going to be super compliant with, usually because it takes a lot of time. They may have to have like a vest put on that will actually kind of percuss the chest to help clear the secretions. You can do it manually, but again, teenagers, do they oftentimes like to do what you tell them to do? You have all been teenagers somewhat recently in the grand scheme of time. You probably did not do what your parents told you to do, I would imagine. Unless you're all just excellent people. You're good students, so maybe you're good teenagers too? Maybe? No? Okay. I don't hear a lot of things, so I'm going to assume that was the case. But yeah, it takes a while, right? It can take 20, 30 minutes, and then you got to do it 1 to 4 times a day. So this is another thing that you really want to make sure they're being compliant with. If they're in the hospital, it's easier because again, they don't really have a choice. They're kind of a captive audience at that point. But it's when they go home is when you can see that they don't really stick with their CPT like they should. They don't get their inhalation antibiotics and things like that. That's typically what leads to a lot of these exacerbations. So looking at aerosolized antibiotics. So this is a good way we can actually get high concentrations to the source itself in order to overcome the fact that when you give a drug IV, the lungs typically are hard to penetrate. And again, if you think about the apparent volume of distribution of the lungs in patients with CF, it's just so full of all that mucus and stuff, it actually has a much higher volume of distribution. So it's harder to really get sufficient concentrations in there. So what we're going to do, and we'll typically use inhaled as an adjunct to IV therapy additionally, and you may actually find that patients will go home on inhalational therapy. They won't go home on IVs typically, they'll go home on inhalational. And you may see things like cycling, like they'll do maybe 28 days on and then maybe 28 days off, and that kind of helps to relieve some of that selective pressure on those bacteria and hopefully helps to lead to a little bit less resistance. So typical things we would use include like our aminoglycosides. Does that have good activity against Pseudomonas? Aminoglycosides definitely kill Pseudomonas, and again, you're getting a lot higher concentrations by inhaling it, so as opposed to giving an IV. So even if you did have something that may be resistant to, say, IV tobramycin, I could potentially do inhalational tobramycin and still have some efficacy, right? Because resistance is only a matter of concentration, but in order for some resistant bugs to get IV concentrations high enough, that may also harm the patient, which is what our limiting factor is. Gentamicin, amikacin, I've seen all of these being aerosolized. Toby is actually just one that is a brand name that you can is marketed specifically for that. Other ones include things like cholestyramine or colistin. This is one that actually is super toxic if you were to give it, say, IV, so we don't use it that way, but by giving it inhalationally, we find that they don't really get systemic absorption very much, and they don't really have a lot of toxicity from that standpoint. So it's a good from an inhalational standpoint. Even sometimes we use ceftazidime. Anyone remember what class this falls into? Cephalosporin. What generation? The third, right? Now remember what we said about ceftazidime many months ago? Pseudomonas gets resistant to ceftaz pretty quickly, which is why we don't use that as one of our go-tos. Say if you had a patient with like a healthcare-associated pneumonia, you wouldn't jump to that one, but you could use it inhalationally because again, it's going to be high concentrations there. So what can we do to actually like break up those secretions and actually help to clear it a little bit easier? Because again, are your antibiotics going to be super effective if your lungs are all blocked up with this mucus? They won't really be able to penetrate as well. So frequently what you'll find is we'll get something to help break up the mucus. Anyone know a term for that? Mucolytic, right? We'll break up the mucus, we'll do the chest physiotherapy to get rid of it, and then we'll give them the antibiotics once things are kind of cleared out as much as possible. One thing we can do is called pulmozyme, or Dornase alpha is the generic name here. This is actually a DNA enzyme. It'll start to cleave up DNA that it finds in that mucus itself, and it helps to break it up. Makes it a little bit easier to clear. And again, it's mainly focusing on a lot of these neutrophils and things that have kind of migrated into that mucus, right? So by breaking that up helps to reduce that viscosity and will allow them to clear it a little bit easier for those patients. You typically will find this is actually very expensive because it is an enzyme you have to produce there. So it may be something you add on after a few of the other therapies we'll mention as well. Other things we can do though is similar to, say we did like an osmotic laxative. We talked about those, how that draws a lot of water into, say, the stool to help clear it easier. We can do kind of similar things in the lungs. We actually give hypertonic saline. So again, we mentioned normal saline is what concentration of NaCl? 0.9%. This is much higher. This is 7% saline. And again, by giving this hyperosmotic, very concentrated saline, it helps to, when it gets in the mucus, helps to draw some of that water in. So again, that helps to reduce the viscosity, makes it easier for them to clear there. We call that rheologic properties, things that help to make things flow better, okay? So that's a term you can use for that. So again, you're gonna have better hydration of the airway surface, better transport of that mucus, and clear that a little bit better. So again, when they have these pulmonary exacerbations, start off pretty aggressive. So when you want to get them IV hydration, tank them up, start to help clear that mucus there, and then get antibiotics on board there. And again, we're going to be using pretty maximal doses, as you'll find. The nice thing with these patients is actually their kidney function usually remains really good throughout. So you can have CF patients who have really excellent kidney functions. You can really push the doses on a lot of these antibiotics. And in fact, you'll find that they may clear these drugs actually better than patients without CF, in which cases that means we have to also give higher doses in order to account for the fact they're clearing it so quickly. And so you're going to see here that a couple different antibiotics we're going to be using, and again, based off their past selectivities. But let's say you had like a brand new patient who's coming in, you don't have any previous records or anything, they don't know what antibiotics they've ever received. If you wanted to cover for Pseudomonas, what are some options that we could go with? So Zosyn, which is what? Piperacillin, tazobactam, so what class is that? So it's penicillin, right? So anti-pseudomonal penicillin for sure. So what else could I use? Cefepime would be a good one, right? It's a 4th gen cephalosporin. Would I use piperacillin and cefepime together?
Oh yeah. Never.
Never? Why not?
Same
mechanism, right? I don't want 2 beta-lactams on board at the same time, right? So I want to have complementary mechanisms. So not use the 2 together. But what other things could I use? Yeah, carbapenem is another really good option. Frequently, we may start patients off on cefepime or, say, Zosyn or something, and then work them up to a carbapenem based off resistance patterns. What are some examples of a carbapenem? Meropenem, imipenem, doripenem. So there are different options that are there. So there's that. What other things could I use? So those are all the carbapenems for the most part. Estrinium would also fit into that category as well. What other mechanism could we go with? We talked about, fluoroquinolones would be a good option, right? So you may see like Levaquin on these patients or ciprofloxacin potentially. Usually Levaquin's I find most often. What other things? So would vancomycin get Pseudomonas? What does it vancomycin get? All gram-positive, right, and MRSA. We just talked about the aminoglycosides. Those can also be used, so gentamicin, tobramycin, etc. Those are the main ones you're going to typically run into for the most part. So you see we have some treatment options, but again, those may dwindle down as the bacteria get more resistant, or if certain things start to pop up, certain atypical bugs, not atypical bacteria, but bugs that are atypical for a typical patient. So, and again, here's things you can see with these patients before they actually come in, or they may be complaining of prior to coming to the ER to get evaluated before they get admitted. Again, you're going to probably run into this in other classes, but in terms of antibiotics, sometimes what we'll do is we'll have them, say, try them out on like an outpatient course. Say they're not so severe they need to come into the ER, for instance. But to get things like Staph aureus, remember we can use, if we're not really thinking MRSA, we can use things like our anti-staphylococcal penicillin. So this is where things like dicloxacillin comes into play. But certainly other meds like cephalexin, clindamycin, augmentin, any of these would be totally fine. Macrolides will also help to get that Staphylococcus aureus. Sorry, it's early in the morning. When I say macrolides, what can that include? Erythromycin, clarithromycin, what's the big one? Azithromycin, absolutely good. For H. flu, typical covers like you would see with that, amoxicillin, more likely than not, they'll probably end up on augmentin. What's the benefit of adding clavulanic acid? The beta-lactamase inhibitor, right? It helps that amoxicillin work a lot better than it would. And then for Pseudomonas, again, typically you'd see for outpatient use like an oral ciprofloxacin, or again, you could end up using your inhalational colistin, or maybe an aminoglycoside like tobramycin. But let's say they come in, remember, what's the thing with covering for Pseudomonas? It's one of the rare instances where you double cover, right? So that's why I was mentioning using complementary mechanisms. So I could use like a carbapenem plus a fluoroquinolone, or an aminoglycoside plus anti-pseudomonal penicillin, right? So keep in mind kind of what would be kind of smart from a drug therapy standpoint in terms of combining your different classes together. Most often, the majority of patients I see start off on an aminoglycoside plus an anti-pseudomonal beta-lactam. So typically piperacillin tazobactam, or say cefepime plus an aminoglycoside. That provides pretty good coverage from that standpoint. Yes, sir?
Was it just found that 2 is just so much superior to 1 in treatment?
You're more likely to, you're casting a wider net, right? Because we know they're going to be harboring this Pseudomonas for years and years and years. They've probably received recent courses of antibiotics, which are helping to provide that selective pressure. It's going to be resistant, so you just know that. And so by double covering, that we're more likely to actually get a better kill for that bacteria itself. Just like if you have like a healthcare-associated pneumonia and they're coming into the ICU, you're going to double cover for Pseudomonas regardless if it's something that's on your differential. Here, for these patients here, you just know Pseudomonas is likely going to be there. It's 9 times out of 10 you'd see that. And again, occasionally you may need actually a third antibiotic, and this is if you're recovering for one of these other kind of late presenting bugs, things like Burkholderia cepacia, stuff like Bactrim may be used for there. If I have Staph aureus and I'm worried about MRSA, what's a go-to? Vancomycin, right? Vancomycin is your go-to IV gram-positive killer. Here, MRSA specifically, it'll certainly get that. But again, as I mentioned, their kidney function is typically really good. So for instance, like with a typical adult patient, I may be dosing vancomycin, say Q12, Q24 hours, depending on renal function. These kids are absolutely going to need like Q6 hour dosing. They're going to need really high doses because they just clear it so fast. And again, what's an important thing to monitor with vancomycin in terms of levels? The peak or the trough? Remember, the trough is important. Why is the trough important? Remember the time-dependent killer? Remember that thing we talked about last semester? Last decade we talked about that? It was a long time ago, but we talked about it. And it's a time-dependent killer, so you want that trough above the MIC as long as you can. And again, the lungs are hard to penetrate. So again, vancomycin has a really tough time getting those high enough concentrations to kill that. So we had to drive it pretty high there. For amine glycosides, again, we're going to find that with these patients, we actually end up doing, because they clear it so fast, and we want to make sure that they get high enough levels, we actually will end up checking for peaks and troughs for these patients here. We want to make sure that the peaks are going to be high enough to get a good kill, because again, they're concentration-dependent killers, and then we want to make sure they're actually clearing the drug itself. And so frequently, we'll get multiple levels for these patients to make sure that it's going to get high enough to kill the bacteria, and then they clear it out to where they don't accumulate it. And what kind of toxicity could you see from accumulating an aminoglycoside? Ototoxicity, what else? Nephrotoxicity, those are the 2 big ones we worry about, right? And again, so you'll find they'll clear it well enough that these troughs are going to be undetectable. So frequently we're more often adjusting to make sure the peaks are high enough rather than we would the trough necessarily, because most of the time their kidneys are great. So as I mentioned, due to their changes in pharmacokinetics, because they have this just big reservoir of mucus and things for drugs to partition into, the volume distribution goes up pretty significantly here, and that again will drive your concentrations down, so that's why you have to give bigger doses. And also they have less lean body mass. Why is that? Because they can't absorb nutrition as well as the patient without CF, right? So again, typically these patients are fairly thin for the most part. And again, their kidneys are working well, so you're going to be clearing the drug very well. So not only do you have volume distribution to deal with, but increased clearance, such that you're going to find that getting adequate serum concentrations. Typically, you're kind of chasing your tail in a little bit because you keep trying to drive up the dose to get something that's going to be effective for them. And so again, looked previously to see what they were on before, what kind of doses resulted in therapeutic concentrations, and go with that in the next time, right? Okay, so some other things we can give for these patients in terms of like anti-inflammatories to help with all that inflammation they kind of chronically have going on. Certainly we can try for like an acute exacerbation, starting off with some corticosteroids, right? So we can things like prednisone, dexamethasone, whatnot. Actually, what you end up finding more often than not is these patients will end up being on chronic macrolide therapy. So azithromycin itself has some anti-inflammatory properties. So if you ever see a patient on Monday, Wednesday, Friday azithromycin with no like stop date on it, that's typically they're using it for the anti-inflammatory properties. And this is, at least I've ever seen it, is in a CF patient. There might be some other cases where you'd use it. And so you're using that, so typically they'll have like azithromycin on just for the anti-inflammatory propries. They'll be on 2 meds for Pseudomonas and maybe on MRSA coverage with vancomycin. So you can see the antibiotic coverage is going to be pretty significant here. What kind of risks does that put them at? And all these antibiotics and your gut flora is getting wiped out. C. diff, right? So again, you got to think about kind of the consequences of putting these patients on all these medications potentially. And if they're not improving, that's where you got to start to consider things like fungal cultures, looking for mycobacteria and things like that, because they could be potentially harboring them, because again, they don't really have that competent of an immune system from the lung standpoint. So as I mentioned with nutrition, again, they also have a lot of increased work of breathing because their lungs are so junky that that also helps to increase their caloric, how many calories they're burning, metabolism's up. They're also not absorbing very well. So there's some things that we can do for these patients to help out with that. One, of course, being their diet, including a high protein, high calorie diet, relatively normal amounts of fat for the most part. But again, we'll see some ways we can aid that absorption. And so this is where we can do pancreatic enzyme replacement. And so you'll actually find this, there's a couple different brands here, things like Pancreas and Creon and Zenpep. You'll kind of get familiar if you see these types of patients. But basically it includes things like lipase, protease, and amylase. Those are things that your pancreas will normally be sending out from an exocrine function that have been blocked up. So we can help to replace this. And basically you adjust the dose based on if they're gaining weight, you base it on how their stools look and things like that. And so, for instance, we'd base it off the lipase content. So again, if they're having steatorrhea, then they're not getting enough lipase, you'd increase the dose for them. So just as an example there, usually you'll find you'll see like Creon 36 or something. That's just the amount of how many units of lipase it has in the actual dosage form. And so you'll see them eat frequent meals for the most part. So you may have them, you'll see like 2 orders. You'll see one for, say, like 6 caps of Creon with meals, and then they'll have another one that says like 3 to 4 caps with snacks. They may eat 3 or 4 snacks throughout the day to help kind of get their caloric intake in. So again, don't worry about the dosing here specifically, but just know that again, we're basing off that lipase content there. There actually is some issues there. We can only drive it up so high, unfortunately, because you can actually develop colonic strictures because of this. Maybe all the extra enzymes we're giving starts to actually break down some of the colon material and causes maybe some it's like scar tissue or something in the form. But basically the strictures are one thing we worried about there. From a gastrointestinal standpoint, we can also supplement them with extra fat-soluble vitamins. So they'll frequently be on a multivitamin that is going to be high in A, D, E, and K. So like Aquadex is a common one, or like Source CF. FCF in the name, so you know exactly what that's for there. And again, that's going to be helpful to supplement that. Occasionally, we'll actually give them things like IV supplementation. So say, for instance, their INR was up. We know that's a result of low vitamin K levels. I can give them a IV dose of vitamin K. The benefit of that is, what's the bioavailability of IV vitamin K? 100%. I don't have to worry about the GI tract, right? From the biliary cirrhosis standpoint, again, we can give that ursodiol, the Actigol, and that helps to supplement what they cannot send out, because again, their biliary tract is usually pretty blocked up from that standpoint. It helps to decrease all that cholesterol content of the bile itself, right? And then in some cases, you may actually even need transplant. I've not seen that personally, but that could be a potential. From a gastroesophageal reflux standpoint here, certainly what can we do for patients with GERD and CF? What do you think? You can help to reduce the acid, right? So you can give antacids, you can use H2 blockers, you can use PPIs for sure. In some cases, we don't want to use a cholinergic agonist because the cholinergic agonist would presumably do what for us? Drive up secretions, but also stimulates what in the GI tract? Peristalsis, right? And that's the reason why they're having that reflux, is because their things are not moving along. So in this case here, you don't want to give a cholinergic because that can actually exacerbate the blockage there, because that mucus is not going to be as easily secreted in these CF patients. We don't want to use any kind of cholinergic agonist. So this is kind of the newer agent, newer class. There's a few other ones that have come out on the market since, but I kind of want to use this as kind of the example agent here. But this is called a combination of lumacaftor and ivacaftor. This is actually pretty neat because it works specifically for that delta F508 deletion. That is, again, the most common mutation you find with these patients here. And essentially what it does is it helps to stimulate that CFTR transporter to be more functional. So for instance here, the lumacaftor helps to provide the better stability for that transporter, and it increases how much of it is actually being processed through transcription and translation and all of that, and gets more of it out to the cell surface. The other thing it's going to do, the ivacaftor portion of it, is actually going to help to make it work better. So we're getting more of the proteins out to the cell surface, and they're going to be working better as a combination of both of these drugs here. Typically, we take these with fatty foods for these patients because, again, it helps aids with the absorption for them. And for the most part, there's not really a ton of side effects you end up seeing, but it's pretty well tolerated. May see some issues, in terms of like menstrual irregularities. This may be more common in patients who are on oral contraceptives, right? But for the most part, pretty well tolerated. And just to give you an example of what this looks like, so say for instance, here's what a normal set of proteins would look like for patients without CF. Here's what the defective one would look like. Notice here it's not getting to the cell surface. Here, if they're receiving the drug, then more of it would get up to the top. Better transmission of the chloride. So again, it's going to help with those secretions pretty significantly. So that's pretty much it for CF patients. It's good to know things like, what kind of antibiotic coverage you might want to provide for them. If you were thinking about the order of pulmonary meds to provide for those patients, what do you think would be the appropriate order? So say I got a patient who's got really junky sounding lungs. I got inhaled antibiotics I want to give them. I maybe have some albuterol I want to give them as a bronchodilator. I have some mucolytics I want to give them, and I'm thinking about my chest physiotherapy. What do you think is going to be like the proper order for all of that? You want to use the mucolytic first? Why? It's going to help to break it up, right? That's going to help what to work better? Your chest physiotherapy will work a little bit better, right? So that's going to help them to get up more of that mucus there. So good. So you start off with your mucolytics, things like your hypertonic saline, maybe your Dornase. I've seen patients on both. Then do your CPT to get rid of that, and then what would you do next? Why bronchodilator? Yeah, so the antibiotics can actually penetrate deeper, right? So you're opening up all those bronchioles, and then finally your antibiotics. That'll probably be the last thing I'll add on in those cases there to make sure they can kind of penetrate as deep as possible to get all that, kind of resistant mucoid-producing Pseudomonas kind of hanging out there, colonizing the patient. Very good. Let's go ahead and do a 10-minute break. We'll come back, and then we'll get started with our GI section here. This will be a quick one, though. So I had a question up on the board. Someone asked, do we use inhaled antibiotics for anything other than CF patients? Why wouldn't that be first-line treatment for pneumonia or bronchitis if it has better penetration and less systemic side effects? It's a good question. Why do you think that is? Money? Could be money. Toby's pretty expensive. Any other ideas? Would there be any side effects with inhaled antibiotics? You can't see bronchospasms, not super common, but it could be a risk there. But when a patient has pneumonia, is it just bacteria in the lungs? How'd the bacteria get there in the first place? Could it have hematogenous spread? Could it have been a UTI that eventually developed into a pneumonia? So typically, because again, when you have a patient, it's not they show up and they say, I have pneumonia. Like, they may be right, but they may have other things that are going on as well. So by casting a little bit wider net, by giving systemic antibiotics, you kind of eradicate everything. So, and again, these CF patients, they may be outpatient-wise, they may just be on, say, inhaled tobramycin, say, daily for 28 days and then off. That's more for suppression therapy. It's not for actual treatment of an infection. We still give them systemic antibiotics because, again, these patients are not susceptible to other infections, and so we want to make sure we cover for that stuff as well. So it's a good thought, but that's, again, why we kind of cast a little bit wider net in those cases there. Any other questions? Okay. let's continue on. So we're talking about some GI disorders in kids. So you'll find a lot of this is going to be pretty similar to what we talked about, say, for more general adult patients. We'll talk about a few things that are a little bit more unique to children, some things to really be concerned with. Actually, I have a really good instance here when we talk about laxatives. I'll have a good mention of a thing I saw yesterday. But basically, when looking at things like GERD in infancy, it's a fairly common thing. Kids spit up quite a bit. Some of it may be due to more of an anatomical sort of issue, may require surgery in some cases there, but it's not uncommon that you'll end up giving infants things like H2 blockers for GERD symptoms and things like that. So fairly common. We see that generally as they get older, hopefully a lot of that resolves, but may not depending on the case. When talking about GERD symptoms, though, is there any kind of issues you might think from using say if like you had a kid and you were giving them, say, chronic, say, PPIs, like any issues that might pop up, you think? But yeah, why bone issues? Why? Yeah, I remember, so you got to think about things like, okay, could there be any issues with the bones? Clinically, I don't know if it comes up too often, but it's certainly a concern, right? You want to make sure you're getting good supplementation of calcium and vitamin D because they may have impaired absorption if you're chronically sort of raising that pH there in the stomach. So little things to think about in terms of that. For these patients, though, certainly if they have any sort of esophagitis, we want to definitely help deal with that. And again, we'll use a little bit of our bigger guns there. But again, we want to make sure they're eating normally, they're gaining weight like they should, make sure they're on their growth curve. All that's fairly normal for them, and so we can help out with that with our medications. Certainly, lifestyle modifications can really help out with this. So dietary modification for them. Is it easy to tell like a 3-year-old what to eat? Not really. I mean, you can tell them what to eat, but they're just not going to listen to you. So, and you'll find that's a pretty common problem for a lot of kids is that they tend to be picky eaters, and then that tends to, if they have something that really just upsets their stomach, that's not great. Or they may shy away from certain foods because maybe they had a bad experience. So it can be kind of tough. But we'll look at the pharmacologic therapy. Certainly, reflux surgery is a possibility too if things are not kind of improving. For infants, though, we can look at things like, why are they having this reflux? It could be any degree of like lactose intolerance. It could be an issue. Sometimes by switching up their formula a little bit or maybe thickening it up with things like rice cereal can help out. Just depends. Typically they'll avoid things like caffeine, chocolate, spicy foods. I would never give my child any caffeine whatsoever for fear of them never sleeping again. But yeah, so just be cautious with that stuff. But certainly we accidentally gave one of them chocolate, like an hour or two before bed, and it was a bad night. It was just not great. So you gotta be cautious with that stuff. Certainly in terms of acid suppression, antacids, probably not going to use too commonly for this kind of patient population. Palatability can be a big issue for them, but I do see quite frequently a lot of H2 blockers. So what are some options for H2 blockers we could use? Ranitidine is a very common one. What else? Famotidine is another good one. Nizatidine, good. So what's the fourth one? We don't go there, right? Good, very good. I've trained you all well. What is that one that we don't use? The H2 blocker that shall not be named, cimetidine, right? The Voldemort of H2 blockers. Right? Right, so proton pump inhibitors could also be used. What are some options there? Omeprazole, its cousin, esomeprazole, right? Lansoprazole. And some of those are available over the counter. All the H2 blockers are available over the counter as well. So find out if they've tried anything before, see what's worked for them, what's not, etc. And then we have a couple prokinetic agents, right? So if the issue is they're just not kind of passing the food like they should, peristalsis is the issue. This is where we can use our prokinetics. What are the options there? Metoclopramide, right? Or Reglan, good. Also helps out with nausea, vomiting. What was the other one? Erythromycin, very good. Yeah, remember that acts on that motilin receptor there. So remember, with the antacids, again, the palatability can be a big issue, so liquid medications are typically going to be preferred for kids because they have a hard time swallowing, obviously. They may not be at that point in terms of development yet. And the palatability, I mean, like drinking Maalox, I don't know if anyone's ever done that, but it's kind of chalky tasting, like it's not great from a palatability standpoint. So giving kids medications may be a difficulty here as well. Not only that, but throwing other medications, a lot of the antacids will bind them up, will prevent them from being absorbed, and you can lead to a lot of drug interactions there. In terms of mucosal protectants, we will use Carafate on somewhat regular basis there. I don't really see any sodium alginates. Another option though from an over-the-counter sort of standpoint. But Carafate can be used. It is nice because it coats everything essentially, and can, especially if they're having any esophagitis, can definitely help out and help to promote a little bit more healing there. As I mentioned with the prokinetics, certainly metoclopramide is somewhat common. There are going to be some issues with that. We'll actually talk more about that in the behavioral section coming up next in terms of, because normally how does metoclopramide work for nausea vomiting? It blocks which receptor? Yeah, dopamine 2, right? So it blocks D2 receptors, and we'll see that there's going to be some issues we can develop with that a little bit later on. So that one I see used a little less commonly. I have some, for nausea and vomiting, it's totally fine medication there. We use it all the time, especially in the post-anesthesia care unit for sure, but then erythromycin I do see quite frequently, right? So we'll use that. The doses are going to be typically lower than what you would see for like an actual like true infection. So certainly could there be a risk for resistance and things like C. diff? Yeah, but it doesn't come up all that too often there, right? The biggest things you're going to see with Reglan though is that if you're using higher doses or using chronically, there are issues. You can develop sort of a pseudo-Parkinson-like effect from using that in the long term. We'll talk much more at length about that in the next section there, so we'll kind of come back to that. Because remember, metoclopramide falls in that same category with other antipsychotic agents we'll get to in the behavioral health section. As I mentioned with the erythromycin, biggest thing though to worry about with this one is just the drug interactions, right? This is one of the stronger ones in terms of inhibiting things like CYP3A4, so you do have to watch out for that, make sure there's no significant interactions causing levels to rise up too high, you can see toxicity. As I mentioned with the H2 blockers, this is easy, cheap for the most part. You'll find a lot of kids with reflux will end up getting put on one of these, at least at the baseline. Usually ranitidine is probably the most common one just because it has a nice readily available liquid formulation, so I see that quite frequent. Just remember to avoid that dirty cimetidine. PPIs I'm starting to see used more in children. Again, we don't have a lot of studies specifically that says, hey, this is totally good for kids, but with enough anecdotal use, you end up seeing that it gets kind of done more and more frequently there. So certainly any of these are totally fine. But remember what I said in terms of taking a PPI orally. Remember it comes in those capsules, it has those little beads in it. What do we say about that? Don't crush or chew them, right? Because why? Now remember, the acid will make the drug ineffective, and so those are acid-stable coatings there. And once it gets down to the small intestine, pH rises, it melts that off, and then the drug can be absorbed. Well, that may be all well and good, but how could I give that capsule to a child? They don't take capsules. So I can open it up, and I can sprinkle it onto something like some applesauce or something, or some pudding or something. Like that would be totally reasonable. You can definitely get away with that. We actually do compound some liquid preparations though. And how do you think we melt off that coating and make it into a solution? We actually use bicarbs. We'll actually mix the PPI with bicarb. We'll melt off that coating and we'll put it into solution. The nice thing too, that bicarb actually helps to neutralize some of that stomach acid as it goes down and allows them to have a little bit better time absorbing it. So that's one thing you may see. You still see some liquid preparations, but it's usually like custom compounded by the pharmacy themselves. So with constipation with kids, this is a super common occurrence in the ER. I probably have mentioned the story before, but I've had like my cousin one time called me up. His daughter was probably like 3 or 4 at the time. And he said, she's in so much pain. We're going to the ER. I don't know if she's going to die or not. I was like, she's just constipated. No, she's not. This is the worst stomach pain ever. Stomach's about to explode. And she's just constipated. And sure enough, x-rays show FOS, right? Full of stool. So really common complaint here. And again, why are kids so likely to get constipated here in the U.S.? Their diet, right? Mac and cheese, and they're eating like crackers and all kinds of stuff that does not contain a lot of non-digestible fiber. So this is a common thing you'll see there. Again, some of it may be related to underlying disease. So we mentioned like CF could be a reason why these kids are constipated due to secretory issues. Tends to be a lot of times functional, right? Because again, if it's hard to pass stools and they kind of associate that with a bad experience, what are they going to do? They start holding, right? And so that can lead to some behavioral issues you can see there. So they may just want to hold on to it, and then they don't realize that's what's causing a lot of their stomach pain, and then we have to deal with it in the ER, right, or the urgent care setting there. So again, that's really a big thing, because again, their involuntary internal sphincter may be working just fine, but it's the external one that they're holding on to it. That's what's going to cause a lot of that backup that can occur there. So you'll typically see that the stooling habits for children will change pretty drastically as they get older. Usually that first week of life, it may be like 4 stools a day, maybe even a couple times more than that. And then as they start to change their diet, say they're going off like say breastfeeding and they're going on to like solid food, you'll certainly see it change. Does anyone know if like baby poop smells bad? It actually doesn't. It doesn't smell all that bad. It's when they start eating solids is when everything starts smelling awful, right? But I'm trying to warn some of you who may have children one day, maybe dealing with children, but that's something you'll see there because again, their gut biome's changing there. They're starting to digest stuff they've never digested before. You'll start to see those number of stoolings start to decrease, so maybe 1 to 2 a day, up to around 4 years or so. It should be pretty close to adults in terms of how often they're doing that. So what we're going to find here is that things that lead to that painful defecation, things that can lead to them kind of exhibiting some more of those holding patterns, tends to be if they have like kind of traumatic experiences. You know, if parents are like really stressing for them to, you know, potty train. Like I mentioned, there's an article that my wife sent me. It was talking about potty training, and it was saying that starting them too early sometimes actually causes them, especially like around year 2 or so, they're actually saying that that causes them to start holding. And again, what happens to all those muscles when they start holding? They start to hypertrophy, and it can actually lead to them causing some retention issues because the muscles are kind of maturing a little bit too early, so to speak. So that's kind of what they're postulating there. But regardless, again, you know, do kids like, or they're playing, they're having a good time, they say, I need to go to the bathroom right now. No, they just want to keep playing and playing and playing until you force them to go to the bathroom or they have an accident or something. So a lot of these things can lead to some of this functional constipation here. Certainly diet's going to be another big factor. Are they getting enough water, getting enough fiber, et cetera, right? And again, you know, KUB is going to be the biggest thing to help you diagnose this. You'll see just a ton of stools just kind of all kept up in the colon there. As I mentioned, with these patients here, a lot of it's going to be functional, but it could be underlying other diseases, things like hypothyroidism or CF could be another big one there. We will find that with kids that are breastfed versus, say, if they're formula fed, that can also have pretty big effects on how often they're stooling. And again, I only mention this because treatment of constipation for, say, like an infant or like a newborn is going to differ than if you're going to be for an older kid. We'll talk about some of the dangers there. Anyway, so what can we do for these patients? Obviously, you can educate not them, but maybe their caregivers. Manual disimpaction can also be one that can be useful, but we're going to talk about obviously the pharmacologic side of things. The goal, though, is we'd like to make sure they're having bowel movements at least once or twice a day, and introducing those dietary and behavioral sort of modifications. So in terms of fecal impaction, how we can manage this. So if it's oral, some patients like that, especially a little bit older ones. Oral is pretty good because they at least have some control over it. You're going to find that adherence may be a bit of an issue, especially if some of the therapies are not going to be well tolerated, though. Typically for rectal disimpaction with medications especially, you tend to find that they are very fast, they work very well, but they're going to be more invasive, right? So you can imagine like giving an enema to like a teenager, they're going to really be on board with that. Not as likely as if it's like, you know, 2 or 3-year-old, they probably don't really care, right? So you kind of have to know your audience there. But, you know, I had this old school Peds EM guy. You know, if you had, doesn't matter if it's teenagers or anyone coming in, if they were complaining of constipation, everyone got an enema. He said, they're coming to the ER, we're going to give them, get their money's worth, right? So I said, okay, you do you, man. We'll talk about some issues with that. Certainly from an oral standpoint, frequently we can either, you know, all the same classes are going to apply here, whether it be stool softeners, you know, what are some issues with using like stimulants, stimulant laxatives? Yeah, they come physically dependent on that. So that's not going to be something we use very frequently, but we may use occasionally. So for instance, if a kid's coming in complaining of really bad constipation, abdominal pain, and they can't clear it in the ER, then they may get admitted for a GI clean out. That's a case where we'd use sort of an intermittent stimulant laxative, and then they go home with, say, something that's better for more kind of chronic maintenance therapy, as we'll look at. In terms of this, we can use things like hyperosmotic agents, so things like mineral oil can be used. Polyethylene glycol, anyone remember the brand names for that? Yeah, Go Lightly or Miralax. Remember, when you think Go Lightly, you want to think about like the big like 4-liter jug that you're going to have for like a bowel clean out, right? So typically if these kids are getting admitted for a bowel clean out, we'll actually place an NG tube because drinking all of that is not going to be, they're probably not going to want to do that and they'll be non-compliant. So we'll place an NG tube. I'll help out with that. If you're thinking like Miralax, that's the typical like routine maintenance of constipation you can use at home typically. So and again, the doses are very different. So for instance, like when you think like Miralax, think like 1 capful is like 17 grams. For the big Go Lightly, it's like 236 or something. So it's a lot more, again, because the goal there is to clean everything out, right? But other things we can use, magnesium hydroxide, mag citrate. Could I use any calcium containing stuff? Why not? Cause of constipation, right? What are kids drinking a lot of typically? Milk could also be playing a role there because of the calcium that calcium is going to be slowing down peristalsis, right? Anyway, so there's a lot of different options here. Typically, senna or bisacodyl, that's going to be better for just sort of like intermittent use, very sporadic, not going to be for more long-term use, right? In terms of rectal use, again, we're using most often going to be hyperosmotic agents. Again, it's going to stimulate the rectum. It's got all that hyperosmotic fluid there. It's going to stimulate defecation pretty strongly. Back in the day, we'd use things like soap suds enemas or tap water enemas to help kind of increase that stretch there to feel like, okay, yeah, they need to defecate. This may be done in adults in some cases, but for the most part with kids, what do you think would be a problem by instilling a bunch of tap water rectally? Well, they may absorb all that water, and what could develop? So electrolyte issues could pop up, right? So they get hyponatremic from absorbing too much of that water, because again, do things absorb very well from the colon and the rectum? Yeah, because they're very thin membranes, so they can absorb that water very easily. Because again, water's going to go where all the solute is, and so it may be internally, and so that can cause hyponatremia. So there's some issues with that. Most of the ones we use are going to be like your Fleet's enemas, which are going to be sodium phosphate based. When I say phosphate soda enemas, so it means sodium phosphate. So if you hear a Fleet enema, that's most frequently what that means. But again, I mentioned that before when we talk about GI, the issue of using that in very young patients is what? It's going to be that hyperphosphatemia, right? So that's the one thing you want to avoid. And again, some kids have died from that before because they got it way too early. So I'll mention yesterday, I had a patient who was basically a resident. So we have all these residents now, right? So what do you think it does in terms of like medication safety? If you have residents now working in a hospital. Not great, right? So they do some interesting things. Sometimes with the hopes that we'll catch it before it goes out, but again, you gotta be really careful, so you gotta watch them like a hawk typically. So basically we had this 18-year-old patient who was in the ICU, had a very complex medical history, had all kinds of issues there, but was also constipated. So I get this order for an adult Fleet's enema. So there's a pediatric one and there's an adult one. So I look at the patient's age, say they're 18 years old, adult looks okay. I look at the weight of the patient, they're 12.2 kilos. And so, is that right? I have to double check. And I checked with the resident, sure enough, it was correct. And so the patient, again, has a host of medical issues. I didn't dig all the way through the chart, but that was correct. They were only 12.2 kilos, very small patient. And so I said, well, yeah, they're an adult legally, right? But do they need an adult size enema? Probably not, right? So I mentioned to him, hey, we should probably end up backing this dose off. Again, the patient has some other issues like hypercalcemia, and if you know anything about calcium and phosphate, what do they like to do to one another? They like to hug together, the hug of death, and bind together. So this is one of those things where we're like, okay, well, I'm really worried about the phosphate levels here. Let's maybe switch it over to like a pediatric one, right? And so again, that's a good intervention that we made there, because even though it's an adult patient, you think, okay, they need an adult enema. It's not really the case. You have to take into account that this is a very unique sort of patient. Other things we can do would be like mineral oil enemas. Glycerin's going to be better for like a newborn. So especially that first month or first year of life for an infant, glycerin suppositories tend to be a little bit safer. They may not be quite as effective, but they tend to be pretty well tolerated for the most part. Again, remember, anytime you put a suppository in the rectum, you got to make sure you give it time to melt. And oftentimes those kids are not going to be necessarily compliant, so you got to maybe hold their cheek shut for a little bit, allow it to melt. Again, it's just nature of the beast, right? Vesicoidal suppositories from a stimulant standpoint can also be used potentially. So a lot of different options that are here. Again, this is going to provide for very quick sort of relief, hopefully, when it works. In terms of maintenance, obviously, increasing fluid intake is going to be a big one. A lot of kids tend to be chronically dehydrated without really noticing it. And sometimes we can actually help them out if they're experiencing some sort of intermittent constipation by providing juices that have these like non-absorbable carbohydrates. So that's where you think about prune juice. Like normally who drinks a lot of prune juice? Old people, right? Why? They get constipated too, right? Whether you're very young or very old, they kind of develop similar problems, right? So this is one of those cases there where using like pear juice or apple juice can be helpful because it helps to kind of stimulate that along. Again, from a hyperosmotic sort of standpoint, right? And then just a balanced diet, make sure you're getting more grains and fruits and vegetables and stuff, which may be difficult depending on the pickiness of the eater. And from a behavioral standpoint, again, making sure they have like unhurried time, or they have like more structured time. So say like every 2 hours, make sure they're sitting on the toilet, make sure they're going. Things like that can be somewhat useful. In terms of daily maintenance, so say you don't need something to completely evacuate them at the moment, this is where daily treatment, typically things that are non-stimulant based are going to be more preferred here. So things like mineral oil and magnesium hydroxide can be used. Be aware though, what could be the risk there? Diarrhea could be an issue, so you do want to be cautious with that. As I mentioned, no chronic use of stimulant laxatives in those cases there. But if every once in a while, certainly Senna or bisacodyl could certainly be used. Okay, as I mentioned with infants here, you're going to find that treatment's pretty similar. I just mentioned that using the glycerin suppositories are going to be more preferred because again, they're better from a safety standpoint than using like a hyper sodium phosphate enema that's going to cause hyperphosphatemia potentially. And typically we don't use stimulants in that age group either. Anyways, any questions on the Peds stuff? I have all this extra time, and I'm going to use it, so I can't let you guys go. You gotta make sure you're getting what you paid for, right? You're like, not really, no thanks. I just came for the degree, not for the lectures. Too bad. All right. So no question on that stuff. All right, moving forward, now we get into behavioral medicine. This is another kind of a beast of a topic, similar to neuro, I would say, in terms of, if you're thinking about the spiciness of the meatball, it's pretty spicy, right? So anyway, let's get into something that many of you may have developed while here over the past few months. Just kidding. You guys are all happy, right? You're going to be happy. Now, so this is a big thing you're going to see in just a ton of patients. And is this going to be, over, underdiagnosed? What do you think? Typically underdiagnosed. A lot of patients tend to be depressed or they have anxiety, and it's not really has ever been addressed. The patient may not understand it, may not realize it. What they're feeling is what this is. But we're starting to see that we're getting rid of some of that stigma. It's getting a little bit more well-known, well-recognized, and so typically more patients are now getting the care that they really need. Because obviously, what is the biggest risk with untreated depressed patient? Suicide, right? And so did I see a lot of this in my training? Toxicology? Yes, that was probably 75% of our patients were trying to commit self-harm with medications typically, right? And guess what a lot of these patients were taking? Anything that was available to them, including their antidepressants. And so we're going to see that this is a really big issue, and we'll find that, especially too, in like adolescents and kids, one of the big risks of starting antidepressants is, anyone know? Increased suicide risk, right? Have you covered a lot of this with Professor Austin so far? Maybe. I think you have like a simulation coming up soon. Soon-ish. When is that? Oh, fantastic. I'll be there for it. We can debrief together, talk about meds and whatnot. But anyway, keep in mind there's a lot of, say, secondary causes for depression and anxiety in these patients here you have to address. So, things like Parkinson's disease, we mentioned, can lead to some of that anhedonia, right? So things you just don't really find a lot of joy in things anymore. Medication can be a big one too. So like isotretinoin is a big one. So yeah, you feel better, your face looks better because you treated your acne, but now you feel kind of depressed because of the drug as well. So again, sometimes a little bit of a double-edged sword there. A lot of your CNS depressants, alcohol, cardiovascular meds, a lot of these can also end up leading to exacerbation of depression. A lot of times it may not cause it as a new onset sort of thing, but it may exacerbate kind of what was there, kind of what was underlying to begin with. Hormonal therapy can be another big one as well. So corticosteroids tend to make people a little bit more cranky, can exacerbate depression. Oral contraceptives, anything affecting like estrogen and progesterone may also be playing a role here. Some patients have their moods improved with oral contraceptives, some patients have their mood worsened, so it just really depends. And again, if it's underdiagnosed and undertreated, a lot of these patients end up trying to commit suicide, which again, fortunately we find that a lot of medication-based overdoses tend to be unsuccessful, but a lot of the medications we use nowadays for depression tend to be a lot safer. They have a lot wider therapeutic index. We'll kind of go through the transition of the really early ones and how dangerous those really were from an overdose standpoint and some of the issues that we see there. Now again, anxiety and depression kind of go hand in hand with one another. Oftentimes they exacerbate one another. We'll find that there's a lot of different types of anxiety disorders for sure, things like panic disorders and obsessive compulsive disorders. We'll get into those as well. And again, you'll typically find that the treatment between the two are almost identical, right? So for the most part, like what would you say is your first line drug for depression? Probably an SSRI, right? What would be your go-to for anxiety? Chronic management anxiety. An SSRI, right? So you're going to find that you typically treat both together in a lot of cases. We'll get into that as we go forward there. One time I had a case of obsessive compulsive disorder so bad that they labeled it CDO instead. So OCD. It's alphabetical. Thank you. All jokes are better when you have to explain them. So, anyway, so looking at this, we're going to find that do we have like a unified theory for why our antidepressants work? Not really, right? So this is going to be one of those sets of drugs where we know what the drugs do, but we don't know why they work for depression like they do. A lot of this is initially thought to be, say, due to depressed levels of monoamines, right, or catecholamines. So things like serotonin, norepinephrine, and dopamine. We're going to be talking about these a lot in this section here. And the reason why we thought that for a while is because we actually found that if you gave a drug that depleted those monoamines, there was this old school drug that was an antihypertensive called reserpine that actually just depleted all those catecholamines, kind of basically exhausted the sympathetic nervous system, that a lot of those patients developed depression. So say, okay, that must be the reason why the patients are depressed. And it's probably more complicated than that because, again, we can give medications that boost serotonin levels at the synapse, but does that mean the antidepressants will work immediately? That'll take weeks to work. So it can't be just related to the levels of monoamines, it has to be something else going on. So there's probably some very complicated downstream sort of cell signaling changes that are occurring that we just don't really have a full idea or a full grasp on in those cases there. So again, oftentimes you don't have to know why the drugs are working, you just need to know that they work and how to use them effectively, right? So for our patients, obviously, if they're having an acute bout of depression, we want to get that sort of under control and help them kind of maintain normal levels of functioning, make sure they can get up and go to work and clean their house and do all those things they should normally be doing if they're kind of a typical functional sort of patient there. And hopefully prevent any kind of relapses, prevent any further episodes from occurring. So in terms of treatment, you'll find there's kind of three main phases here, starting out with kind of the acute phase early on. Hopefully we get remission of symptoms there. They have more of a continuation phase where you may be working with some of those residual symptoms, and then the maintenance phase. So it's kind of where most patients are going to be at any given time on that kind of maintenance phase. And we'll see how we kind of maintain that in a little bit. Typically, a lot of patients, unless it's very situational while they're having depression, like maybe it's more of a postpartum thing, or maybe it's related to a certain event, a lot of patients may require lifetime therapy, especially if they have kind of recurrent episodes of that. So it's just one thing to consider. But adherence is going to be a huge thing with this one, right? So for instance, if you're depressed, do you necessarily want to take your medications? Not really, right? You just want to lay in bed and you don't want to do anything, or however your depression manifests. Oftentimes adherence can be a big issue there, so it can be a challenge to get them to even stick with their medications in the first place. So certainly you're going to find that by using non-pharmacologic methods in conjunction with your meds, that they will work much better together. And so it's really important that we involve, things like cognitive behavioral therapy. Even in some cases we would use electroconvulsive therapy, right? It's shocking that we would do that, but even there's been some interesting studies looking at repetitive transcranial magnetic stimulation, where they actually basically use these magnets on the forehead, and they've actually found some help with depression there as well. So there's a lot of different modalities that patients can try. Again, do things like, do you think that TMS actually gets like good insurance coverage? Not really, because a lot of these things may not be as proven as a typical antidepressant might be, and so sometimes reimbursement can be difficult for this stuff, may be expensive for the patient. So a lot of it is just kind of dependent on kind of what sort of resources the patient has. But focusing on the pharmacologic therapy, because you're pharm class, you're going to find that in terms of like actual therapeutic effect with these drugs, there's a placebo effect is going to be a big thing, right? So placebo effect is essentially what? Your brain tricks you, right? So mind over matter. And in fact, that is a very powerful force. So if you're depressed and you start taking a sugar pill, but someone told you it was an antidepressant, and you said, here, this will make you feel better, and you think, okay, I'm doing something that's going to make me feel better, is there a chance the patient might start to feel better? They're doing something for themselves, they're starting to take some agency over their life, they're feeling better. Yeah, absolutely. So placebo effect is really difficult to control for. You can have these trials where giving patients who are depressed placebo versus giving them an actual antidepressant, they may actually find somewhat similar results. Maybe a little bit better in the antidepressant group, but the placebo effect is strong here. So a lot of times it's hard to tell, like, is our patient really responding well to it, or are they just kind of feeling better because of the mind over matter aspect of it? But the reason why you'll find some patients that just don't respond well to antidepressants at all, right? Either due to the fact that they're having side effects, or the drug may not be working very well for them. So how we decide which one we're going to start off with, and we said SSRI before, and that's kind of a good safe go-to, but we'll look at some different factors there why we might choose one versus another. But look at things like, what have they tried before? What has not worked for them? What kind of side effects did they experience while they were on it? And things like that, because frequently the side effect profile is what's going to lead you to choosing one class versus another, because they generally have pretty similar efficacy with all of that. And again, think about patient preference too, like, do they want to try something herbal? We'll talk about an option for that a little bit later. What's an herbal antidepressant drug you can use? St. John's wort, right? So we'll talk about some other options that are there for patients. I'll talk about that one briefly because that does have some pretty big implications in terms of therapy and side effects, and so we'll mention that one there. I know I don't go into a lot of herbal drugs, but that's certainly one to make mention of. So how do we classify our antidepressants? So either typically based off of their chemical structure. So when you say something like a tricyclic antidepressant, that's referring to the actual structure of the drug, or it's going to be based on the mechanism. So when you say selective serotonin reuptake inhibitor, that's the mechanism, right? And so again, it helps you to kind of classify, okay, what kind of side effects might I see with these drugs? What kind of effects can you expect when a patient's on that? Other caveats to note is that antidepressant therapy takes a couple of weeks to really kick in, right? Maybe 2 to 6 weeks before you really start to see full effects. When do they start getting side effects? immediately potentially, right? So they're going to have a side effect. It can manifest initially. And so they're like, here, keep taking this. You may feel miserable. You may feel worse before you feel better. Is that going to help out with adherence? Generally, no. So that's one of the other hurdles we're going to have to kind of cross in order to make sure the patients are going to stay adherent to this stuff. Some of them may diminish over time. Some of them may be pretty chronic. So what are some like typical, pretty problematic side effects from an antidepressant that may cause someone to quit? Maybe anxiety can actually worsen anxiety in some patients, but something else. GI maybe. But the sexual side effects tend to be pretty common, right? And so a lot of patients, if they all of a sudden are taking an antidepressant and want to have sex with their partner, and all of a sudden they can't because of the antidepressant, are they going to want to keep taking that medication? No, right? So again, the sexual side effects tend to be a big problem with these as well. You tend to see like weight gain with certain classes. You tend to see a lot of different side effects. We'll look at those and choosing kind of which one's going to be best for our patient depending on kind of what side effects they particularly are manifesting. Again, there's a big intrinsic failure rate, and you'll see this when you go on your behavioral rotation. You say, well, which antidepressant do you start with? You kind of have your pick, right? It doesn't really, there's not one gold standard to start with because, again, there's a high failure rate and there's a wide swath of people that respond very differently to these medications there. And of course, you know, if a patient's coming back and you ask them, say, hey, have you been taking your antidepressant like I told you to, but they've been depressed and haven't been taking it, are they going to tell you that necessarily? Perhaps not, right? So sometimes they can be intelligently non-compliant and you're just like, okay, well, the drug doesn't appear to be working, but they really haven't been taking it in the first place. So that could be another issue you run into. You're going to find that typically in terms of your antidepressants, most of the classes are going to work fairly similar in terms of efficacy, but the side effect profile is what's really going to change here. So especially with your old school drugs like your MAOIs and your TCAs, they tend to be much more problematic in terms of side effects. Also, these are really bad in terms of overdoses, and we'll talk about that briefly as we go forward. I'm not going to turn this into a tox lecture, but certainly this is a big concern with these patients here. We'll talk about the black box warnings and all of that. So looking at sort of our classifications of meds here, we're going to start off with sort of the older agents, and we'll kind of work our way through time to the more newer, more selective agents here. And so if you talked about monoamine oxidase inhibitors before? Yep. Probably, so we'll talk about those real briefly. How those work, we'll talk about TCAs, and then we'll get into kind of the newer classes like your SSRIs and your SNRIs as well. So it's a kind of a complicated slide here, but I think it illustrates a lot of good points in terms of how these medications are specifically working. So when I say monoamine oxidase inhibitor, we've covered this before, right? Where did we cover that? Parkinson's, right? We talked about monoamine oxidase B inhibitors, things like selegiline or rasagiline. These are going to be non-selective, right? So they kind of work on a lot of different types of catecholamines. So here you're going to find by blocking MAO, what does that do for us? So it's going to decrease metabolism of what? Dopamine potentially. What else? Well, what's your happy neurochemical? Serotonin is going to affect serotonin. Very good. What else? Norepinephrine is going to be a big one, right? So we mentioned those are three big neurotransmitters we're going to be talking about here in terms of use, right, for depression. So norepinephrine and serotonin more specifically, those are the more important ones in terms of talking about depression. But by blocking the breakdown of those, you have a higher amount of them. You have a higher amount that can be sent out to the synapse, and thus they can activate those postsynaptic neurons, right? So it makes sense. You have more serotonin, you feel happier, there you go, right? Again, that's why they originally thought these were working. We're going to find there's a lot of side effects associated with that, though, okay? So just by blanket increasing the amount of catecholamines you have available, that can lead to some big issues, as we'll see a little bit later on. How do, like, our SSRIs work? Well, what does SSRI stand for? Selective serotonin reuptake inhibitor. Good. So this actually blocks this transporter here. So by blocking the reuptake of serotonin, more of it is left out in the synapse, and then it can interact with those 5-HT receptors there. Okay. That's, again, you think, okay, well, yeah, increase serotonin levels, patient should be happy now, right? But no, it still takes a few weeks. So there's something happening downstream here that is leading to the changes in mood and changes in anxiety that these patients will develop. We don't know why or what, but there's something happening, right? How about with your TCAs? How do they differ in terms of activity between like an SSRI? So TCAs are going to block reuptake of serotonin, but they also block reuptake of norepinephrine. So norepinephrine is going to be playing a role here as well. Okay, blocking reuptake there again leads to more activity at the postsynaptic neuron, and that may have some help with depression as well. How about your SNRIs? Those are going to be more selective. They have some activity at serotonin, but they may also have some activity at norepinephrine. So that's what the difference is between SNRI and SSRI. The big difference between TCAs and SNRIs is going to be all the other stuff that TCAs do. They're very dirty drugs in terms of their mechanism. They'll do lots of other things, as we'll see in just a little bit. We'll talk about lithium a little bit later. That has kind of its own novel mechanism. Lithium is typically used for what? Bipolar disorder, right? So you have to kind of think like, okay, does the patient have depression and manic episodes, right? So you'll find some overlap in treatment there as well. So basically what you're going to find that by enhancing the effects of serotonin and 5-HT, especially chronically over the course of several weeks, we will see that it does help to improve mood. Again, you may find that depending on the type of drug you're using, this may actually worsen anxiety, or it may actually help with anxiety depending on which set of drugs you're using. Which one of these neurotransmitters do you think would be worse at causing anxiety? Why norepinephrine? Yeah, it's your fight or flight response, right? You think about your sympathetic nervous system when you're running away from a stressor, that's your norepinephrine firing off there from those neurons. So it makes sense that by increasing that, you could worsen anxiety, because what is anxiety? It's a maladaptive stress response, right? So it's something that is like you're in a hypersympathetic state anyway because of whatever stress that you're feeling, whatever anxiety you have there. So again, we'll talk about some more issues with that later on. But again, downstream effects, right? So maybe changes in G proteins, maybe changes in transcription factors. All that eventually is what leads to those changes. And again, 2 to 6 weeks before you really start to see full effects. So getting into the MAOIs first. So we're going to find that actually initially iproniazid was one of the first anti-tuberculosis agents we had there. And actually there's even a drug earlier than that. Anyone ever heard of methylene blue? The dye they used to use, and actually it's a treatment for methemoglobinemia. Ever developed that? You give a blue patient a blue drug and they turn pink again. That's what I always like to say. But methylene blue, they used to give it to patients in these like psych wards and things back in the day because it would actually turn your urine blue. So what do you think it does for adherence? If you're peeing blue, then I can see that you're taking your medications like you're supposed to, right? You mentioned adherence is a problem for these patients. Well, after giving this methylene blue to these patients, they actually found their mood was starting to improve. It's like, oh, cool, they're actually taking their meds, they're starting to feel better. And so from there, we started to develop a lot of the initial medications that work for depression, also schizophrenia, as we'll see a little bit later on. But iproniazid is one of the first ones here. And then from then on, we have things like phenelzine, we have isocarboxazid, and then tranylcypromine. Again, these are going to be irreversible inhibitors of MAO-A and MAO-B. So what do you think are the implications of an irreversible inhibition? The effects are going to be short or long-acting? Long-acting, because we have to generate new monoamine oxidase before we can have functional metabolism of norepinephrine and serotonin and dopamine again. So this means that even though a patient may have stopped the medication, they can still have effects several weeks after as they start to develop more of that MAO, as those old enzymes that have been irreversibly inhibited get metabolized off, right? You're also going to find that not only will this affect endogenous catecholamines we've already produced, but it also affects exogenous ones as well. So remember we talked about the tyramine reactions that occurred with, say, taking selegiline in a patient with Parkinson's? What kind of foods were those that had high tyramine? Bougie foods, what does that mean? Aged cheeses, some, what kind of wine? Red wine, nice Chiantis, and Merlots, aged meats, all those kind of things, right? Things you'd have at fancy parties. I don't know what kind of parties you guys have. Would like a White Claw party be a problem? Probably not, right? But a lot of foods you can't have, but those are the ones you have to be really considerate of. And again, a lot of food-drug interactions you're going to see with those drugs there. So as I mentioned, phenelzine, tranylcypromine, these are probably the most common ones you'd run into from a clinical standpoint. And then selegiline, as we mentioned, used for Parkinson's specifically. That one was only a monoamine oxidase B inhibitor versus the other two are going to be non-specific. They work for both A and B there, right? So adverse effects, as you might expect, are pretty numerous with these. So you can see things like postural hypotension. This is fairly common, especially in older patients, maybe because they can't regulate things like norepinephrine as well as they used to, so that can affect how well they're able to clamp down on those vessels when they go from a sitting to standing position, right? Typically, with most of these antidepressants, you're going to find, especially these early ones, weight gain is going to be a big side effect. You're going to find sexual side effects can also be a big issue as well. So either just decreased libido, they may have anorgasmia where they can't actually achieve climax. Like there's a lot of issues that can develop from that. And again, with patients when they're depressed, what happens to their weight typically? Depends, right? It can go up or it can go down depending on kind of how their depression manifests. So maybe they overeat, maybe they undereat. So that can be a thing you'll see with the antidepressants as well. Some of them will cause them to cause weight gain, but they'll just start eating a bunch, which could be a problem if they're overweight, or it could actually cause them to be more anorexic and then actually cause them to lose weight. So it kind of depends on the patient, right, and how they're going to manifest this stuff. So again, that's why it's such a scattershot. Like, we'll try something, see how it works, and if that doesn't, then we'll switch to something else. The other big, really dangerous thing you worry about is going to be this hypertensive crisis, right? And when do you think this would occur? This is going to be when you have the tyramine reaction that we were just talking about a second ago, right? So say they go to one of those parties, they consume a bunch of aged cheeses and red wine and aged meats and all those things. All of a sudden they start getting this like pounding headache, they start getting nauseous, start getting blurry vision. A lot of it can be related to that hypertensive crisis they're developing because of the fact that all those tyramine is getting converted over into things like norepinephrine and epinephrine, and that's causing way too much sympathetic activation, way too much blood pressure is skyrocketing. And again, it's led to stroke before, led to MI before, and caused death. So that's something you have to be really considerate of with these agents here. Especially if they have any history of hypertension, this may not be a great set of drugs to put them on. And remember, it takes about 2 weeks or so to regenerate this enzyme. So just because they stop taking their tranylcypromine and they say, wow, I'm not feeling depressed anymore, I'm going to stop my medication, now let me go to that nice party, and they can still have a reaction, right, several weeks afterwards. So one thing to be considerate of. Is there any other meds we've ever talked about that also affects MAO? Maybe not be used for behavioral health issues? Maybe as an anti-infective, perhaps? Remember Zyvox or linezolid we talked about before? What is that drug used for? VRE, right? So anything, or VRSA, anything that's resistant to vancomycin from a gram-positive standpoint, Zyvox can be used, right? That actually has similar MAO activity there. So it could be an issue where if you're combining this, say an MAO your patient was on, MAOI plus something like Zyvox, you could definitely lead to the same issues here, right? So that one is another consideration. Or mixing different antidepressants together can also lead to the same effect, especially like an SSRI or an SNRI, you know? And when do you think patients would ever take these together? So what if they weren't educated properly, right? If you don't tell them, hey, stop taking this medication, start taking this new one. Think that's ever happened before? Yeah, patients don't always get the communication to you. They don't always get the message that you're sending out there. Or if they're trying to commit suicide, right? They may have this old drug lying around. They just go and take whatever they can find, and that's where you see a lot of these interactions as well. So one thing to consider. Again, how would you treat that? Just typical antihypertensives will work there. You could use IV labetalol or enalaprilat or anything like that would certainly work. So as I mentioned, the tyramine reactions here, you know, soy sauce, fava beans, licorice, all kinds of different foods. Again, you'd be educating your patients specifically. Now, clinically speaking, when you get out there and you're working for 2021 or in 2021, right? It's closer than you might think, right? Yeah, it's going to be coming pretty fast and furious. Do you think you'll ever end up using an MAOI in your life? Very unlikely, actually. We still mention it here because some patients may be on it. They've been on it for many decades, potentially. Just like you probably won't be using a whole lot of theophylline in your future, but you may have patients that have just been on it forever, and that's just how they manage their COPD or their asthma, whatever the case may be. But it's still important to know these interactions here from both a historical standpoint and in case you see these interactions pop up, like you can understand the mechanism of them. Other drugs that can interact with these MAOIs to kind of cause the same effect would be things like amphetamines. We'll talk about ADHD later on, but amphetamines do things like increasing release of catecholamines like dopamine and norepinephrine. You can see how they would interact with one another. If you're blocking the breakdown of the catecholamines and increasing their release, it can be very synergistic, right? Asthma medications like beta-2 agonists can exacerbate this, certainly cocaine, decongestants, you know, a lot of different things, right? Does substance abuse and depression go together sometimes? Certainly, right? So again, it could be other issues you really worry about there. So those are the MAOIs. Moving into the TCAs, now we have our tricyclic antidepressants. And if you look at their chemical structure, they actually look a lot like carbamazepine, if you remember from our neuro section there. These are actually derived from the antipsychotics. And so they kind of fall in this category called phenothiazines. Kind of a chemical classification name for them. These are going to be affecting both the serotonin reuptake protein and also the norepinephrine reuptake protein. Okay, so they're going to increase levels of both of these here. So serotonin and norepinephrine are going to go up together. You'll see that is going to be similar to the SNRIs and how they work. Where the TCAs differ, though, is going to be all the other mechanisms they have there, which makes them really dangerous in terms of both side effects at therapeutic doses and also side effects at higher doses, like an overdose, for instance. You will still see TCAs not being used as first line for depression anymore, but you may see them being used for other purposes. And we'll talk about a few of those a little bit later on. You may see them being used for things like insomnia, because you'll find they're very sedating. You may see them being used for things like bedwetting, and we'll talk about why that is in just a few minutes. They also help out with neuropathic pain, right? Because which neurotransmitter helps out with neuropathic pain? The norepinephrine, right? So just like we saw in things like duloxetine or Cymbalta, which is an SNRI, works for neuropathic pain. These can do the same thing, right? So we mentioned that back in that pain management section a little while ago. So the available agents in the TCA class include things like amoxapine. Amitriptyline is probably the most common one I've actually run into. Clomipramine, disipramine, doxepin is another common one. Imipramine, and then nortriptyline. These three plus amitriptyline are probably the most common ones that I've at least run into clinically. But certainly any of these are certainly fair game for the testing. So you should be able to recognize these as TCAs. So they affect a lot of different receptors, which what makes them so side effect prone and also likely to see a lot of issues with overdose especially. So I kind of lament sometimes that I came up in toxicology when I did, because I kind of came up when like SSRIs were super common. But back in the day, they used to talk about when patients would overdose on TCAs, because that was just how they treated depression. They'd always have like 4 beds in the ER, always set up for TCA overdoses because they're so common. They would come in and they get really, really sick. And these patients are like the most critical ill you might find with some overdoses. Really, really dangerous. The reason why they are is because of their side effect profile, because of their mechanisms here. So one of the big things is they're anticholinergic. So what does that do in terms of like your mental status? So sedation is going to be a big thing at therapeutic dosing, which is why you may see it used for insomnia in some cases, right? How about higher doses? That's why they get mad as a hatter, right? So you can see things like they get agitated, they can start hallucinating, they can get seizures potentially in really high doses, right? So they can affect their mentation pretty significantly. They have all the other anticholinergic side effects. Now, why do you think this would work for, say, bedwetting? Yeah, because it causes urinary retention, so you'd be less likely to actually have urination during the nighttime. You have that nocturesis, right? So little things like that you can think about, like, why would this work for this indication? Well, think about the mechanism of the drug, and it does make some sense there, right? They get very tachycardic as well when they have the anticholinergic effect sort of manifesting there. Not only that, but they also block sodium channels. And so this can be really dangerous because they'll block sodium channels on the heart. That ends up prolonging the QRS, and we can actually see them being at big risk for ventricular arrhythmia. So again, another big reason why these are dangerous, of the actual arrhythmias they develop on top of the seizures they can also get. They also can cause hypotension, which again may be problematic in elderly patients. So they actually block alpha-1 receptors. We know that alpha-1 is typically vasoconstrictive, right? And then other kind of usual things, sexual dysfunction, weight gain, and again, do that antihistamine action has as well. You'll see some sedation additionally, right? In addition to the anticholinergic effects. So again, why do we use these for depression back in the day if they cause all these different issues? Kind of all we had, right? So this was before the advent of things like SSRI. So the therapeutic index for these drugs was fairly narrow, but again, if I don't treat the depression, then that may ultimately be worse potentially. So then we move into the SSRIs, right? So these are actually the kind of go-to gold standard for most patients who are going to be starting off on treatment for depression or, let's say, chronic maintenance of anxiety potentially. And so these are nice because they're very specific in how they work. Instead of working on alpha receptors and cholinergic receptors and all these different things, they just work on the serotonin transporter. They only block the reuptake of serotonin, and so that helps to make it much more clean in terms of mechanism, helps to also make it much better in terms of side effect profile. Very safe in overdose. I've seen patients take handfuls and handfuls of their SSRI. They do pretty well, right? If you take a handful of a TCA, you might not make it through the day, right? Just to give you an idea of the difference in safety profiles between the two classes of drug here, very tolerable. And again, what's a big risk when patients are first starting off on a antidepressant drug? You might try to commit suicide, and you think, well, why is that? Do these drugs cause you to be suicidal? Not necessarily, right? But again, when you're depressed, you have not a whole lot of energy. You may have thoughts of harming yourself, but do you act on them necessarily? Well, maybe not, because you're kind of so low energy. You're like, maybe tomorrow I'll do that, right? I don't really think about it. But once you start off on these SSRIs, they kind of give you a little bit more energy, right? And so now all of a sudden they have enough energy. Anyone know a term where you kind of like just feel like ants in your pants, kind of like just can't sit still? What a term for that's called? Akathisia. We'll talk about that, especially with our dopamine blocking drugs. If you ever hear akathisia, it's kind of like just you feel like you got ants crawling your skin practically. That increase in energy can lead them to actually act on those thoughts. And so that's kind of the theory behind it, is why this increase in suicidality occurs, because now they can have the energy to act on their thoughts of self-harm. So again, this is one of the big risks. And again, I'd rather have a patient overdose on an SSRI 10 times out of 10 than I would something like a TCA or a monoamine oxidase inhibitor. I'd prefer them not to commit suicide at all, but if they're going to attempt it, SSRI is not a extremely dangerous one in the grand scheme of things. So the agents we have here, so we have citalopram and we have escitalopram. So again, you guys know the relationship between those two. Escitalopram is the enantiomer of citalopram, right? So you could do like a dose conversion between those two. So 10 milligrams of citalopram would be equivalent to how many milligrams of escitalopram? It'd be half, right? So 5, right? Because again, it's just the enantiomer of citalopram, right? Remember that kind of relationship between racemic mixtures and their individual enantiomers. Next we have fluoxetine or Prozac. That was probably one of the big first ones that came out that was like kind of blockbuster sort of medication there. Fluvoxamine, paroxetine, and then sertraline are kind of these are the most common SSRIs you're going to run into. And so as I mentioned, they have very low affinity for all those other receptors that the TCAs did, so they have a very nice safety profile. They will still cause some weight gain potentially. Some patients maybe not. Again, that's going to be less likely though than you would see with your TCAs. And most often the patients are going to complain of maybe some anxiety initially. They may complain of some insomnia or headache, and then sexual disturbances may be a big reason for discontinuation. Many people will develop that either decreased libido or they may have that anorgasmia and want to switch over to something else potentially. So I don't have much more time than that, so I think I'm going to go ahead and cut it here and see if there's any questions. Any questions from you all? I'll have you here. Yes, ma'am.
So it's kind of like a double question.
I only like triple questions.
So why does what mechanism makes it cause like the sexual disturbances?
Well, if you think about it, it can either do with the actual like reflex arcs, and we'll talk more about that when we get into, actually I covered this in physiology back when I taught that, so you may have covered it with Professor Kaplan at some point. But it has to do with some of the reflex arcs that occur to actually cause for actual erection and orgasm to occur, or just orgasms in females. Some of it may be related more to sort of response to external stimuli, right? So they may actually have that decreased libido, where it's just like they could still have sex, but they just don't feel like it, right? So it could be multiple different things there. Sometimes by affecting norepinephrine, that can also affect those reflex arcs and may make it more difficult to achieve climax. It just depends on the person and the drug.
And then like you say like they switch to something else, but like if they all have like the same effect.
We will talk about one that causes that less than the others, and we'll mention that later. So I'm going to save that in my back pocket for the next time we meet.